guided as well. So this thing is happening, but still, when a facility is available, I would like to argue the 3D with O-arm guided screws are the perfect for the perfect screws. What exactly is a perfect screw? Perfect screw is something where there's no breach in the pedicle border at all. None of the borders are breached. An adequate length and diameter. This is also very important for the stability of the construct itself. Not only safety of the patient, but also safety of the operation theater personnel and surgeons as well. The work should also be smooth, and that should be proved by clinical studies as well. So we know through the process that it's all started with the freehand technique, then we moved on to fluoroscopic guided, then we went to navigation guided, then we are moving to robot now. And this has been our journey. All of us have gone through this journey, first to the fluoroscopic, then fluoroscopy with navigation, and then now with the 3D O-arm base. So this is what we are trying to avoid. These are the different kinds of breaches happen with all different technologies. This is what we are avoid, and we are debating here which is the best. This is what I use. There are different types of navigation platforms are available, different types of intra-op CTs are available. This is what I use. I won't go to the detail of this. Basically, as you know, it's a 2D fluoro with a 3D reconstruction is available. There's a flat panel and X-ray source inside this itself. The gantry rotates. Most important thing we need to know, the CT, the radiation dose in a O-arm in a load is much, much lower than this thing. So obviously, the radiation will be much less when you use a O-arm dose. So this is what we are trying to achieve here. Perfect screws, and this is possible only with a good quality CT scan, getting an axial and a sagittal view. So that's only accurate is best in a case of a 3D with a C-arm. This is a normal workflow which happens. We use a Jackson table, position the patient, then we put the reference arc. Then you can see accurately, we can find out the site of the skin incision. Then you put the pack needle inside. And once the pack needle is inside, we'll put the guide wire there and remove the pack needle off, and then use the rest of the procedure is you use the tap to the same extent. You navigate the tap as well, plus the screw as well. And the best thing to do is while you can also see the length of the screws what is required. You can also find the diameter of the screws. See, that's accurately you can place it. So that's the advantage. In real time, you can see that your screw is going in a proper position. So what are the key benefits? First thing is the radiation. Just a minimal radiation at all. We know while doing a freehand or with a fluoroscopic how much X-rays we shoot. And it's a precise, real time, you can make out the screw position itself. Good in redo surgeries and complex deformity, useful in cervicothoracic and cervicothoracic and CV junction cases. And ultimately, it reduces the surgical time as well. So how it is better? What are the drawbacks of the 2D flow? It lacks high accuracy. You know, multiple true and AP lateral has to be taken. More you take X-rays, and you need a scale radiographer as well. More you take X-rays, you are really exposed to radiation. It is a time consuming, and obviously difficult in a case of CV junction and cardiothoracic, cervicothoracic region. And inadequate quality of the imaging you get when your patient is obese, deformity, and osteoporosis. So we know we have been training, as a trainee, we have been taught these 3 points. So to be accurate, we try to do more and more X-ray, and our radiation exposure increases. And in complex deformities like this and small and sclerotic pedicles, it will be very, very difficult to do either freehand, fluoroscopic, or even a 2D navigation as well. And what are the disadvantages of a 2D fluoro navigation? The accuracy is lesser than a 3D. Poor imaging at the cervicothoracic and the craniocervical junction. Again, measuring the screw diameter and length is very, very difficult because you are not getting an axial view, and accuracy of the implant cannot be checked at all. In a 3D O-arm, we can do a navigation on the table again and check it as well. And these are the things we have seen many times when you do a 2D fluoro. This identification of the trackers on the screen becomes very, very difficult. The workflow is not as smooth as it. So definitely there will be a problem with the workflow. So I don't think this is definitely better than a 3D C-arm. 3D C-arm or the 3D CT scan. So I'll skip through this. The quality is also poor. So what are the advantages? MIS is a precise screw placement is possible, particularly in a deformity cases. not only you put a screw, there's this O-arm shoot can also help you find out the amount of decompression if occur. And if you're doing tumor surgeries, we know how much tumor you are taken out as well. Revision spine surgeries, and even in osteoporosis and obese patient, it gives an accurate placement of the screws and the decompression as well. I will show you some cervical cases. You can see the cervical also, accurate placement of the lateral mass screws, plus the tap and the pedicle can be seen. Lack of time, I'll just skip this. So what I'm basically telling you, you can do at the CV junction as well, plus cervicothoracic junction as well. You can use these, use with a worm. Even in a thoracic stabilization, just because of lack of time, I'll skip this video. Now let us do the literature. I reviewed all the literatures from year 2000 to 2024. All the literatures say using a standard technique, definitely the malplaced screws are much, much higher. Here in this study also you can make out non-navigated screws, there's 9.7% risk of breach, but in a navigated screws it's only about 3.7%. It's got better and better. This is another study in 2014 which clearly says if the conventional fluoroscopy, it is around just about 68% accurate. With 2D fluoroscopy, it is 84. It's around 3D navigation, it's around 95% accurate. Again, another study clearly shows fluoroscopy around 12% risk of breach, but it just has reduced with the navigated screws to 3%. The mother of all studies is this one, where you can see this came in 2019 with 50,000 screws. They have studied a comprehensive systematic review and meta-analysis of around more than 50,000 screws, comparing all the modalities, freehand with fluoroscopy, with 2D navigation and plus 3D navigation, and clearly say the accuracy rate is very, very high in a 3D with 3D navigation, which is around 95%. And even in a thoracic spine as well, the accuracy is much, much more when you use a CT with a navigation. What about radiation exposure? All of us know, and I don't think we need a literature. We've done a literature review. All the literature clearly shows radiation exposure is much, much less when you do a 3D navigation. So that's the biggest advantage of using this. Again, radiation exposure is much reduced, and even in fact half compared to when we use a C-arm. This study came, there's an argument about the cost and the time duration which takes in a 3D navigation. But this study clearly states even the operative time is less, hospital stay is less, in fact the cost comes less as well. Since the revision rates also is less, the overall, the financially, for a hospital also, the cost rate comes out. So cost, it is a cost effective as well.
Please conclude. Yeah.
So I come back to my first slide itself. No breach in the pedicles, absolutely this is the best, because you have seen how it accurately you can place. Next important, adequate length and diameter of the screws. Because you are taking an axial view, you can make out minimal radiation. It's been proved. Workflow is very, very smooth in this compared to this thing. And it's approved with all the studies from 20 to 24. You can see all the studies clearly says that for the perfect screw, it's a 3D arm is the best. So thank you very much.
Thank you, Dr. Abhay.